Hello? Hello? Assalamualaikum.
Salam.
Oh, okay. Fine. Okay, should we start then? So we start with Kita Al-Fatiha. Okay, so there's two seminars that we combine together. It's mainly because this month is not a good month for me. It's been quite a hectic month, so that's why I need to combine two seminars together. So it's going to be a lengthy session today. So there is two topics, mainly about dermatology. I'm just not going to waste time now. I'm just going to invite the those who are presenting to take the floor. Okay.
Okay, Assalamualaikum warahmatullahi wabarakatuh. We are from group Seminar 9. We're going to present about the topic regarding dermatology. My name is Umina Khaimat Yaqub, so I'm going to present about hemangioma. Okay, this is outline throughout my presentation. Okay, for introduction, vascular anomalies that occur among children can be divided into two major categories, which are vascular tumor and vascular malformation. For vascular tumor, are characterized by hypercellularity, proliferation, and growth. An example under vascular tumor are hemangioma and pyogenic granuloma. So more detail about hemangioma. Hemangioma are characterized by phases of proliferation and also involution as defined by a rapid proliferation of blood vessels in the first year of life. And then it followed by gradual regression of the vascular component with replacement by fibrofatty tissue. In contrast, for vascular malformation, there are developmental defects derived from the capillary, venous, arterial, or lymphatic vessel, and they generally do not regress. Next. Okay. Hemangioma are the most common benign vascular tumor. Despite the benign and self-limited nature, some hemangioma also can cause complications, which I will explain later. And its transformation to malignant tumor is rare. Next. For epidemiology, hemangioma are classically said to occur in up to 10%. Next. Okay. It occurs in approximately 5% to 10% of 1 year old infant. Hemangioma are 3 times more common among female than male, with a ratio of 3 to 1. And complicated hemangioma are even more likely to occur among female infants with aneurysm. Okay, the incidence of hemangioma is increased in infant with lower birth weight, and multiple hemangioma are more commonly occur in multiple gestation. And development of hemangioma also associated with a prenatal factor that include all the maternal age, placenta previa, preeclampsia, and other placenta anomalies. So how these are related to development of hemangioma? Next. Okay, as I said before, hemangioma are characterized by phases of proliferation and also involution. And actually, the exact mechanism are incompletely understood. However, there are many evidence that suggest that hypoxia may have a key role in the pathogenesis of hemangioma. There is an association of infantile hemangioma with condition that related with placenta hypoxia. So placenta hypoxia is like an initiating factor that target mainly to those hypoxia inducible factor 1 factor such as factor 1 alpha such as vascular endothelial growth factor A, glucose transporter isoform 1, and insulin-like growth factor 2. Next. So this marked the starting of proliferating phase. It acts as a hemostatic. It attempts to normalize the hypoxic tissue. So based on this picture, if there is a tissue hypoxia, it will be increase in production of growth factor that will promote vasculogenesis and angiogenesis. Then after proliferating phase, involution phase will take over, and the spontaneous involution phase typically begin in the late part of the first year and continue over a variable number of years. This is mainly because of a reduced quantity of growth factor and increased apoptosis that counteract the proliferation and counteract proliferation. Involution is characterized by histologic fibrosis of capillary lymphna. Next. Okay, for the clinical course, hemangioma may be present at birth or first week of life. Clinical course is marked by rapid growth during early infancy, then followed by slower growth, then gradual involution. By 5 years of age, 50% of hemangioma involute, 70% by age 7, and 90% by age 9. So when resolved, a significant minority, about 20 to 40%, leave residual scarring, fibrofatty tissue, telangiectasis, and other skin changes, which can have a lasting psychological effect. So approximately 10% require treatment and less than 1% are life-threatening. Next. Okay. And for the clinical features, the majority of hemangioma are not clinically evident at birth, but become apparent within the first day to month of life. Some newborn have a premonitory cutaneous mark, such as a patch of telangiectasis with rounded pallor. So this early lesion sometimes may be mistaken for a scratch or bruise. And the majority of lesions are solitary. If more than one lesion, there is an increased risk of getting visceral hemangioma. And multiple lesions multiple lesions occur in up to 20% of infants and are especially common among multiple births. And more than 50% of hemangioma relocated at head and neck, but they also can occur anywhere in the skin, mucous membrane, or internal organ. Size is ranging from a few milliliters to several centimeters in diameter. And they may be appeared as the superficial, deep, and also mixed. And for the clinical features, we also need to figure out about the hemangioma morphology that categorized as localized, segmental, and also multiple, because this morphology can provide an important clue to potential complication that the patient might have. Next. Okay, so this is clinical subtype of hemangioma. So they can appear as a superficial hemangioma. Okay, and superficial hemangioma is the most common one. It appears as bright red papule, lobulated plaque or nodule, compressible and sharply demarcated. They can reach maximal size by 6 to 8 months. Next. And this one is deep hemangioma. It's lie deeper in skin with a bluish soft tissue swelling without an overlying superficial component. and it is soft and warm mass, more diffuse and less defined. It may grow for 12 to 14 months. Next. Okay, this picture here show the extension of vasculogenesis between superficial hemangioma and deep hemangioma. Next. And the third one is mid hemangioma. Mixed hemangioma have both deep and superficial hemangioma. Its range from a few milliliter to several centimeter in diameter, and it usually solitary. But they also 20% of cases it also involve multiple lesion. Next, okay, the last one is multiple neonatal hemangiomatosis. It commonly occur 15% to 30%. It consists of multiple small lesions that ranging a few milliliter to 1 to 2 centimeter. For this one, I will explain later. Next. Okay. As I said before, hemangioma morphology it provides an important clue for us to see is there any potential complication that patient might have. Okay. The first one, I talk about complication from localized hemangioma. So most localized hemangioma are complicated and require no intervention. However, some lesions may ulcerate leading to pain, bleeding, scarring, and infection. Okay. The first one in complication is ulceration. Ulceration is the most common complication of hemangioma. Particularly, it frequent when hemangioma are rapidly proliferating and located in trauma operation prone location. Ulceration is often painful and may lead to bleeding, infection, and invariably scarring. Okay. The next one is bleeding. Bleeding is also a common concern among parents, and bleeding is rarely profuse and can generally be stopped with application of direct pressure. Next. Okay, next morphology is segmental lesion. Segmental lesions are usually patch or plug-like and demonstrate a linear or geographic presence over a specific cutaneous territory, and they are much more likely to be associated with complication, and they require more intervention and prolonged therapy and also they have a poorer overall outcome than children with hemangioma of localized morphology. Next. Okay. This is airway hemangioma. The risk of airway hemangioma is higher with segmental hemangioma that located in the cervical fascia mandibular, or we also called as a beard distribution. Okay, the possibility of airway hemangioma must be considered in any child who has a cutaneous hemangioma in this area, and because they tend to develop progressive hoarseness or stridor. So, this symptom may progress from initial hoarseness or stridor to respiratory failure. So, basically, the airway involvement can be confirmed using endoscopic visualization. Okay, the next slide. Next. Periorbital hemangioma. Periorbital hemangioma may compromise normal visual development. The majority of hemangioma that lead to visual complication involve the upper medial eyelid. The picture at the right side. However, hemangioma of any size or morphology in the periorbital location may pose a threat to vision, such as amblyopia, strabismus, and astigmatism. Next. Okay. The next one is the phase syndrome. Phase syndrome is a neurovascular syndrome that defined by the presence of a large segmental hemangioma, usually on the face or head. And they are associated with one or more congenital malformation, most commonly structural or cerebrovascular anomalies of the brain. So if there is a segmental hemangioma on the face, so doctor need to suspect that patient may complicated with other abnormal condition of faces. So with this pneumonic uh, faces, the patient might have posterior fossa structural brain abnormalities, H, hemangioma of the face, head, and neck. A, arterial lesion, C, cardiac anomalies, quotation of aorta and other anomalies. E, eyes abnormalities. S, sternal cleft, and so on. Okay, the next one. Okay, lumbosacral lesion. Okay, hemangioma that located over the lumbar or sacral spine may be associated with other anomalies. Okay, there are several acronyms have been proposed to describe the association of segmental lower body hemangioma with underlying developmental anomalies. With underlying developmental abnormalities, including lumbar, L, lower body hemangioma and other cutaneous defect. U, there is urogenital anomalies, ulceration. M, myelopathy. B, bony deformities. A, anorectal malformation, arterial anomalies, and last one are renal anomalies. And there also for pelvis, perineal hemangioma. When there is a hemangioma at the anal side. So it completed also with E, external genital malformation, L, lipomyelomenicosis, V, vesicorenal abnormalities, R, imperforate anus, S, skin tag and sacral, S, spinal dwarfism, A, anogenital, C, cutaneous, R, renal and urology anomalies, and the last one is angioma of lumbosacral localization. Okay, the next one. Okay, this is accreditation. So approximately 80% of infantile hemangioma occur on the extremities, and this distribution and this large hemangioma in this location, it exhibit a biker glove distribution where which it describes hemangioma that extend on the digit and with sparing the distal tips. Next. Okay. The last hemangioma morphology is multiple lesion. Okay. In most children with multiple lesion, it defined that multiple lesion are defined as more than 5 generally small or localized hemangioma. So they have high increase of getting visceral hemangioma, and the common site that involve internal organ or liver with 43%, GI tract, brain, mediastinum, lung, and the left side involved is pancreas, spleen, bone, or kidney. Okay, visceral, particularly hepatic hemangioma, can cause life-threatening complications. So so the complication listed here is rare, but potential complication of visceral hemangioma, it depends on the specific organ involvement, such as heart failure, massive hepatomegaly, gastrointestinal hemorrhage, obstructive jaundice, and also central nervous system sequelae. Next. Next. Okay. So these are other hemangioma of the ear. The patient might have can have otitis externa, sensory neural hearing loss, and then there are also hemangioma of the tongue, oral cavity, or digestive tract, and also have a knuckle hemangioma. Next. Okay, for diagnosis and investigation, okay, 95% of the diagnosis can be made based on history and physical examination by assessing the typical appearing vascular tumor and some history of the lesion seen at birth or shortly after birth with characteristic proliferation in early infancy. But some situation or condition that may need some additional evaluation. It depends upon the location and morphology of the hemangioma, such as we need to do ultrasound with Doppler if we suspect hepatic hemangioma, do MRI to determine extent of lesion, or is there any structural brain abnormalities. We need to assess the for cardiac evaluation and echocardiography for facial syndrome. Next one. Okay, these are the differential diagnoses that have similar presentation as hemangioma. The first one is capillary malformation. Yes, they have quite similar presentation of macular telangiectatic patch that present at birth, but the difference between them, hemangioma usually it has a surrounding pallor at the telangiectatic patch, and hemangioma quickly begins to develop small vascular nodule and become raised. Okay, second one is Kaposiform hemangioendothelioma and tufted hemangioma. So this one is rapidly proliferating tumor, and they usually associated with Kasabach Merritt phenomenon. Okay, then subcutaneous tumor, deep subcutaneous tumor, particularly when there is no overlying skin changes are present. So this one, tissue biopsy is generally necessary to exclude malignancy. And the last one is pyogenic granuloma. Next. Okay, there are these are the picture. Okay, the first picture is a patch of telangiectasia with a surrounding pallor. So this one, we know that this is represent clinical features for the hemangioma, infantile hemangioma, not capillary malformation. And the second one, the patient will presented with large subcutaneous mass with a purpuric bruise appearance. So this is a clinical feature for Kaposiform hemangioendothelioma. And the picture below at the right side, this one for the clinical feature for tufted angioma, and the last one, pyogenic clinical feature for pyogenic granuloma. Okay, next. Okay, for the management, okay, most hemangioma require no treatment, and active non-intervention is recommended in order to recognize those that are require treatment quickly. So when treatment is undertaken, it is important that it will be customized to the individual patient, and the possible is there a possible physical and psychological complication must be discussed in advance. And often, this management, it needs a multidisciplinary approach. And for individualized to manage individually, it depends on size of the lesion, location of the hemangioma, presence of the complication, age of the patient, and rate of growth or evolution and the type of evolution. So the potential risk of treatment is carefully weighed against the potential benefits. So, management, we classify into non-risk or low-risk hemangioma or high-risk hemangioma. So, for under no-risk or low-risk, the lesion hemangioma usually small, that cause no functional impairment and unlikely to leave permanent disfigurement. So how to manage them? We just need to wait and watch policy, and also for the patient, and also we for the patient education. So this parent in education may include the following: the expected natural history without treatment, and demonstration whenever possible, serial clinical photograph or natural evolution. So basically, this management, we need to observe the growth or and evolution of the hemangioma. And for the high-risk hemangioma, it's a large hemangioma and prognostically poor location. It likely to leave permanent disfigurement that can cause functional impairment, or it involve extracutaneous structure. The one that need to be managed, that need intervention, is those who have a large cutaneous or visceral hemangioma, particularly liver, with which they can result to high output cardiac failure, and the one that hemangioma on the special site with associated complication that I explained just now. Okay, treatment are divided into medical and also surgical. For the medical treatment, okay, the first one is propranolol. Propranolol is the first line treatment. So patients that are admitted to ward for propranolol therapy for should have a close monitoring for is there any adverse effect from the propranolol therapy. Okay, the dose given is start at 0.5 in 2 to 3 divided doses orally, and then it increase if tolerated, and increase its dose by 0.5 is given until reach the optimal therapeutic dose of 1.5 to 2 milligram per kg over day. Okay, the duration is range from 2 to 15 months, but it proposed that propranolol should be continued for 1 year or until the lesion involved completely, as rebound growth had been noted if treatment is withdrawn too early. So propranolol is withdrawn by halving the dose for 2 weeks, then halving again for 2 weeks before stopping. And the adverse effects that should be monitored during propranolol therapy are hypotension, bradycardia, hypoglycemia, bronchospasm, sleep disturbance, diarrhea, hyperkalemia. Okay, so propranolol is a beta blocker. It blocks beta adrenergic receptor, so it mainly to narrow the blood vessel, and it reduces amount of the blood flow to that area. So that's why this for this usually to reduce the development of hemangioma. And the second one is systemic corticosteroid. This one is indicated mainly during the growth period of hemangioma. Okay. The first one is prednisolone. So prednisolone We'll give 2 to 4 milligram per kg per day, single morning dose or divided dose. And it have also side effect, which are growth retardation, blood pressure elevation, insulin resistance, and immunosuppression. And the second one in intralesional corticosteroid. This one is for small bossy and facial hemangioma. The third one is triamcinolone. So this one, it should be also 20 milligram per ml should be injected at low pressure. Use, using a 3-min shrink and 25 guard needle, and must not exceed 3 to 5 milligram per kilogram per procedure. And the last one is other systemic therapy. Okay, we have here interferon alpha. Interferon alpha is very effective, but it is used as second line therapy for lesion that not responsive to corticosteroid, but they have a side effect which they may have a possible severe neurotoxicity, including spastic diplegia. And the last one is vincristine, a second-line treatment for corticosteroid-resistant hemangiomas. Next. Okay, for the surgical treatment, the benefits and risks of surgery must be weighed carefully, since the scar may be worse than the result of spontaneous regression. The surgery is especially good for small pendaculated hemangioma and occasionally in case where there may be functional impairment, and surgical is usually used for repairing residual cosmetic deformities. And generally, it is recommended that a re-evaluation be done when the child is 4 years old in order to assess the potential benefit of excision. Is it good or not to do surgical treatment for others patients with the same same presentation. And the last one is a prognosis. So the prognosis for most uncomplicated infantile hemangioma is good with complete involution. So despite resolution of the vascular component, that so the residual skin changes are observed in roughly 50% of cases, just 50% of cases. So this is my references. That's all. Thank you. Any question?
Okay, thank you very much. Any question to your colleague? So the main thing about hemangioma is the location. So if it around the eyes, around the neck, around the abdominal side, we tend to worry whether there might be an extension to the internal organ or internal structure. So I had recently one patient that had orbital hemangioma, but the hemangioma is not just superficial on the eyes. It actually cause the proptosis, and also there is extension of the hemangioma towards into the brain as well. So it's a very complicated kind of structure that need to be sought out. He is now 11 years old. So the hemangioma affecting his eyesight as well. So this is one of the delayed in the treatment and also delayed consultation by parents lah. So it's very important if you notice just a small hemangioma at the early age, just small over the eyes, just get this one to be scanned, and then probably need a bit early therapy, and rather than leave it too late. So it's very important the location of the hemangioma. because the location will determine on what next you want to do. If you tell him just on the hand, on the legs, he probably just wait and see. But this location, the face, the neck, the abdomen is very important for you to do further testing or further, I would say, further surveillance to make sure it does not involve another internal organ. Okay, any question about this topic before we move on? Okay, no question. There's no question, and then move to eczema, atopic dermatitis.
Okay, Assalamualaikum everyone. So I'm going to continue with the presentation about the atopic dermatitis. Next. Okay, so this is the outline of my presentation. Next. Okay, so for introduction, according to Nelson, so atopic dermatitis is a chronic pruritic relapsing inflammatory skin condition, and according to CPG, it is defined as a complex, chronic and recurrent inflammatory itchy skin disorders. Next. So in epidemiology, so this is the world map of the incidence and lifetime prevalence of atopic dermatitis symptoms from 1990s to 2010s. So if you focus on our Malaysia map, especially on the peninsula, so it is green in color. So the lifetime prevalence of Peninsula Malaysia is about 2.6 to 5%, and it's increasing in that one period of decade. Next. So the estimated prevalence is up to about to 20% in children, and it occurs more frequently in urban areas and higher socioeconomic classes. So according to ISAAC, International Study of Asthma and Allergies in Childhood, the 12-month prevalence of atopic dermatitis among Malaysian children has risen from 9.5% in ISAAC1, conducted in 1994 to 1995, to 12.6% in ISAAC3 in 2002-2003, with an increase of 0.49% yearly. And they also expect that the prevalence will be increasing in the upcoming subsequent years. Next. So on pathophysiology, so the atopic dermatitis are influenced by many factors, especially genetic, environmental triggers, immune system dysregulation, and skin barrier dysfunction. And besides these factors, they actually have two hypotheses, which are inside-out hypothesis and outside-in hypothesis. For inside-out hypothesis, it is due to internal factors such as immune system and genetic that lead to skin barrier dysfunction. Whereas if it's outside in hypothesis, it's due to environmental triggers that causing the immune system to react and causing skin barrier dysfunction. Next. So we look at one by one of the factors. The first one is genetic. So usually in patients who have atopic dermatitis, they have mutation in the filaggrin gene, which encodes filaggrin protein. So the filaggrin protein is actually a major structural protein to produce stratum corneum. So it will so if there is a mutation in the filaggrin protein, it can impair the skin barrier function and increase the risk of atopic dermatitis. So besides the mutation in the filaggrin gene, there is also a polymorphism of the various immune pathway genes, especially the type T helper type 2 signaling pathway, where they can alternate the pathway and upregulate the interleukin 4 and interleukin 13, which subsequently lowers the filaggrin protein expression, causing skin barrier defects. Next. Okay, for the next factors, which is environmental triggers such as anxiety, stress, or climate change, for example, extreme temperature of extreme humidity, irritants such as detergents or soap, allergens such as pollen, dust, cigarette smoke, can exaggerate the cutaneous inflammatory response. by activating the Langerhans cell in the dermis, where it will express surface-bound IgE, causing the stimulation of T cells. So the T cell will initiate and maintain local tissue inflammation through the interleukin-4, interleukin-13, and interleukin-5, and further promote the IgE production and eosinophil differentiation. Next. And then the third factor, which is immune system dysregulation, usually it is related to the type 2 immune cytokine. Before this, like I just mentioned, the type 2 immune cytokine, interleukin 4, interleukin 13, they play a major role in helping the production of the chemokine, causing barrier dysfunction to the skin barrier, suppressing the antimicrobial peptide and allergy inflammation. So where actually the antimicrobial peptide is important for host defense and control of physiological function, for example, inflammation and wound healing. So when there is they dysregulate, they suppress the antimicrobial peptide, this can causing the lack of the host defense and cause a higher predisposition of colonization to by microbes. And also the environmental triggers has been researched where it's found that environmental triggers can actually activate TSLP gene. So TSLP, or thymic stromal lymphoprotein, is another immune pathway gene that can contribute to the development of the atopic dermatitis. So when there is the environmental triggers, it activates the TSLP gene. It is will be highly expressed, further help in development of atopic dermatitis. Next. And last one, for the skin barrier dysfunction, interleukin 4, 13, 31, and 33, they downregulate the production of the epidermal barrier, such proteins such as filaggrin protein, keratins, and cell adhesion molecule, causing damage to the barrier, and also heightens the sensitization to allergens. So this sensitization may as well contribute to the risk of food allergy and airway hyperreactivity, leading to asthma. Besides that, the impairment of the skin barrier also will increase the transepidermal water loss, which we see in later in symptoms of the atopic dermatitis, which is dry skin due to the increased transepidermal water loss. Okay, so I'm going to talk a little bit about atopic march. So atopic march is actually a natural history of atopic manifestation characterized by a typical sequence of atopic diseases in childhood preceding the development of other allergic disorders later in life. Atopic march it consists of atopic dermatitis, asthma, and also allergic rhinitis. So atopic march we can say that it is a progression from atopic dermatitis to allergic rhinitis and asthma. And atopic dermatitis as well is a part of the process to become the atopic march. So if you see in the graph below, this is the graph of the incidence of the atopic march following the years. So usually the atopic dermatitis will be the first one to be manifested, and then followed by food allergy, and later on will subsequently cause development of asthma or allergic rhinitis. Next. Okay. Usually, for patient who have eczema with specific IgE antibody, they have higher risk to develop atopic march than those with eczema but no IgE sensitization, because IgE sensitization to environmental allergen, they can be the contributing factor to progress into allergic phenotype of asthma, causing asthma. And also besides IgE sensitization, the other risk factor to develop asthma as well are early onset and severity of the atopic dermatitis. The more severe the atopic dermatitis, the higher the risk factor to develop asthma. And also, besides that, there has been research that there is a strong association between allergic rhinitis and asthma, because these two diseases actually share same anatomical, physiological, immunopathological, and therapeutic factors. And allergic rhinitis also it is associated with multiple comorbidities, which includes asthma. So allergic rhinitis can be the risk factor for asthma, and it can also precede asthma in the atopic march. So, and next one is how does atopic dermatitis and food allergy coexist? So it is their interaction with each other is very complex, but there has been research done where it said that 50 to 70% of early onset of atopic dermatitis, these patients are sensitized to one or more of the allergens. For example, cow's milk, hen's egg, peanuts, house dust, mite, pollen. So these allergies can actually become the provoking factor, or it can be exacerbating factor for atopic dermatitis. But overall, how does the mechanism in atopic march happen is still largely unknown. But the association are very strong between all four of these diseases. See next. So the clinical features, so the patient with atopic dermatitis come with rash and pruritus. So for rash, they varies according to age based on the distribution of the rash. And atopic dermatitis also, they can be acute and chronic. If it's acute dermatitis, the rash will be papulovesicular eruption with erythema, weeping, edema, and excoriation. If it's chronic, it can become lichenification and dry skin, which is cirrhosis. And then pruritus, itchiness, it can become worsening at night and causing difficulty for the patient to sleep. So the pruritus usually due to disruption of the epidermal barrier, cause and then the exposed epidermal barrier to the allergen can stimulate the cutaneous itch receptor, leading to pruritus. And the pruritus, after a long time, it can become complication, which is excoriation. So from pruritus to excoriation can be acute and chronic. If it's acute, the excoriation can lead to erythema. If it's chronic, it can become lichenification. So lichenification is due to hyperplasia of the subcorneal epidermis, causing skin thickening, and accentuate the skin marking. Okay, is distribution for the rash, if it is infants, usually on the face, scalp, cheeks, and also the extensive surface of extremities. For example, front of the knee, back of the elbow. If it's older children, usually on the antecubital and popliteal fossa. If it's all adolescent and adult, usually in the flexural areas. For example, back of the knee or in the groin, head, and also neck. Next. Okay, since the other pictures, I want to show the rash, the atopic dermatitis rash. Next. So this is the lichenification, the chronic type of atopic dermatitis. That is the palmar hyperlinearity. This is actually a what we call as atopic stigmata, or other presentation of atopic dermatitis, which can help us in diagnosing this disease later. So we can look for this palmar hyperlinearity. Next, dermatographism. Next one, pityriasis alba. And also then this is called as Denny Morgan folds with the creases under the eyelids. And the last one is keratosis pilaris. Okay, next. So the investigation, atopic dermatitis have no specific lab investigation. So they are diagnosed based on clinical features. So the diagnoses are based on two criteria: UK's Working Party's diagnostic criteria and Hanifin and Rajka diagnostic criteria. If in CPG, they said that the UK Working Party's one is have higher sensitivity and specificity rather than Hanifin and Rajka, with about 100% to 99% sensitivity and specificity. But if it's PITS protocol, they use Hanifin and Rajka diagnostic criteria. Next. Next. Okay, so if we use Working Party's diagnostic criteria, so the patient first must have the itchy skin condition of pruritus plus three of the following, which are history of involvement of skin creases, any personal history of asthma or hay fever, history of general dry skin in the last year, any visible flexural eczema, and the onset is under the age of 2. Whereas if Next, if we use the Hanifin and Rajka criteria, we'll have more to tick off the list. We must have 3 of these basic features, which are pruritus, the morphology and distribution, whether it's flexural lichenification or linearity, and the facial extensor involvement, chronic or chronically relapsing dermatitis, and any personal or family history of atopy, plus 3 of the minor features, xerosis, like atopic stomata I just said just now, Danny Morgan intravital fold, pityriasis alba, dermatographism, and many more. Okay, next. So for management of atopic dermatitis, they usually tailor the management according to the individual based on the severity and patient's understanding and expectation of the disease, and also the patient's social circumstances. And for the management, they usually use these two method, which are a bath and emollients, and also topical corticosteroids. So if baths usually used to soothe the itching and remove the crusting by using the lukewarm bath. If it's uses moisturizer, it works to reduce the dryness in the skin by trapping the moisture, and also emollient. Emollient best applied after bath, for example, aqueous cream or Vaseline. And they also use the topical corticosteroid, which acts as anti-inflammatory agent, but the corticosteroid only used for short-term apply. And they also use with least potent corticosteroid in order to prevent side effects. And the next one is a systemic therapy, which their goal is to relieve the pruritus by giving oral antihistamine, treat any secondary infection, and also treat refractory cases in cases if the conventional therapy is not working. So the buff and emollient and topical corticosteroid, they have the step care plan approach, whether to use when to use emollients, when to use corticosteroid, and when to use both. So this one you can read more in the PITS protocol. Okay, next. So the complication. So the complication of atopic dermatitis is a secondary infection due to what I just said about the suppression of the antimicrobial peptide. So they can become infected with bacteria or virus. If it's bacteria, usually Staphylococcus aureus, leading to secondary impetigo. If it's virus, usually by herpes simplex virus, causing eczema hepaticum. Okay, next. So differential diagnosis, besides atopic dermatitis, you can also consider this patient to have if contact dermatitis or seborrheic dermatitis, psoriasis, and Wiskott-Aldrich syndrome. Okay, so that's all for me. So is there any question?
What are the differences between atopic dermatitis with psoriasis?
Usually, this if it's psoriasis, the rash, they are well demarcated, erythematous, and scaling papules and plaque, and usually they involve the nail plate as well if it's psoriasis.
Okay, another question? And normally the psoriasis involve extension of the elbows and sometimes behind the neck as well. So typical psoriasis different to the atopic dermatitis depending on the location as well. Okay, another question, eh? Okay, so obviously atopic dermatitis is very common in children as well. It can happen as soon as early as a couple of months age, so 2 to 3 months. Sometimes it can happen as well because babies tend to have a lot of folded skin. So because of the folded skin, they are sweaty, and that could be the irritant to the skin as well. So it's very important to keep them moisture with the emollients, a lot of emollients as well. I always tell my patient or my parents about emollients. Do use them, lots of them. So do not use them sparingly. It's contrast to the steroids. Steroid, you want to use them very thin layers, but emollient, you can use them. You can buff your skin with emollient because it's not really toxic. Because you want to keep them. You want to trap the water, the moist, condition of the skin. So that's why I told patient that you can use them as much as you can during the daytime. The more you use emollients, the quicker the exacerbation of eczema will resolve. Okay, so thank you very much. So we come for the next topic, which is scabies.
Assalamualaikum warahmatullahi wabarakatuh. My name is Fatin Hanani binti Mahadi and I'll be sharing regarding the scabies. This is my outlines. First, let us go to definitions of the scabies. Scabies comes from the Latin word which means to scratch. It is actually the cutaneous infestation caused by the mite Sarcoptes scabi, which any part of the body may be affected. In epidemiology, scabies is one of the commonest dermatological conditions. Globally, it is estimated that more than 200 million people were affected at any time, where it is endemic in many resource-poor tropical settings, with an estimated average prevalence of 5 to 10% of children. In Malaysia, in 1980s, it was reported that the prevalence was about 11.6%, and it actually high among the children and teenager, with the worst affected being those in year of 5 to 6 years old, which is about 24%. In year 2010, it was documented that the overall prevalence uh, rate for the scabies was about 31% among the children at the welfare house. Okay, as we know that the main culprit for the scabies would be the Sarcoptes scabies. So let us know what is actually the Sarcoptes scabies. Sarcoptes scabies is actually the arthropod class Arachnida, subclass Archaric and family Sarcoptidae, where the mode of transmission primarily would be the skin-to-skin contact, but it also includes in the way of the sharing of the bed, sharing of the clothes, and also the sexual activity. And this makes scabies can spread easily under the crowded condition where the close body and skin contact is common, for example, in nursery, prison, and also the hostel. Not only that, those who are immunocompromised, the elderly, debilitated person are actually has greater risk to develop the severe form of the scabies, which known as the Norwegian scabies or crusted scabies that we will discuss later. And the sexually active person also have risk of getting the Sarcoptes scabies. Okay, next would be regarding the life cycle. The Sarcoptes scabies actually undergo 4 stages in its life cycle, which are the eggs, the larva, the nymphs, and also adult. Okay, the story starts as the mite goes onto the person's skin, and where it will burrow, it will dig into the upper layer of the skin, which is the stratum corneum. The thing is, this mite it will never go deeper than this stratum corneum. The female, as you can see in the slide, it makes a burrow or dig into the stratum corneum. And then the female deposit the eggs, where the eggs are oval in shape, having the length of 0.1 to 0.15 millimeter in length. And about 2 to 3 days later, the egg hatch and it develop a larva, where the larva have only 3 pairs of legs, and the larva then migrate to the skin surface and burrow into the intact corneum to construct another short burrow called known as the molting pouch. And about 3 to 4 days later, it will develop into the nymph stage before it develop into adult, where adult female is slightly larger than adult males. Same goes to this picture. As you can see, the mating occurs as the active male penetrating the molting pouch of the adult female, where the mating takes place only once and leave the female fertile for the rest of her life. The impregnated female leave their molting pouches and wander on the surface of the skin until they find a suitable site for a permanent burrow. As the female found a suitable condition, it will begin to create another burrow and lay egg at that site, just like in that cycle. The thing is, it will stay in that burrow for the rest of her life. Meanwhile, the males are rarely seen and they make temporary shallow pits in the skin to feed until they locate a female's burrow and mate. Okay, this is the details regarding the life cycle of the Sarcoptes scabies. Okay, regarding the clinical features, the incubation periods for those without previous exposure to scabies is actually about 2 to 6 weeks. Meanwhile, those who have been previously infested with the scabies will develop symptoms within 1 to 5 days of the re-exposure. And regarding the symptoms in adult and older children usually present as intensely pruritic rash, usually more apparent at night. What I found, it is apparent at night because the skin is quite warmer. And at the same time, usually there is history of itchiness among the family members within the same periods. Regarding this sign, where you can see from the physical examination, would be characteristic of the small erythematous papulovesicular lesion, the burrows, which appears as the serpiginous, grayish, reddish or brownish lines, about 2 to 15 millimeter long. Another one would be the reddish brown nodules. Actually, the reddish brown nodule is caused by the delayed hypersensitivity reaction towards the female mites. Its eggs and also its feces were deposited in the epidermis rather than by active infection. In this picture, the thing that I would like to highlight is actually generally the lesion or the rashes can occur in every parts of the body. And to compare within the children and also adult, in children, there also involvement of the face. Meanwhile, it is rare in adult for involvement of the face. And in this feature, the thing that I would like to highlight is that among any sites where we can find the signs, the most frequently affected would be where the stratum corneum, the uppermost layer of our skin, is the most thin with fewer hair follicles, therefore easy for the mite to dig and create a burrow and stay in our skin. This site includes the area between the finger, as you can see, those highlighted in pink, between fingers, the wrist, and also the elbow, and also many more. Okay. The features would be look like this, which showing the burrows at the wrist, and also this is the vesiculopustular lesions on both hands and the web of the fingers. Meanwhile, this is the vesiculopustular lesions on lateral aspect of the hands. This showing the papules and burrows on the medial aspect of the feet and nodules over the axillary region, and this at the wrist and also between the finger. Meanwhile, this showing the diffuse erythematous maculopapular eruption and scattered nodules. Okay, as I mentioned earlier, those who are immunocompromised, those who are elderly people, those on long-term corticosteroid, those who have the HIV infection actually have greater risk for developing the severe form of the scabies, which also known as the Norwegian scabies or crusted scabies. It is highly contagious with hyperinfestation of about 2 million live mites at one time. And the pruritus may be minimal or absent, or the host may be physically incapable of scratching. What I found, it is actually might be due to suppression of the sensitivity towards the mites, therefore reducing the itching, and therefore there will be less scratching and destruction of the burrows. And this Norwegian scabies characterized by the diffuse hyperkeratosis associated with the variable degree of underlying erythroderma. As you can see, the presentation can be like the thick scaly skin over the hands, also the hyperkeratosis encrusting gluteal cleft and folds. Okay, as for the diagnosis, making the diagnosis a firm diagnosis for the scabies before the treatment is actually important, because the treatment for the scabies may exaggerate other dermatoses such as atopic dermatitis and can cause unnecessary skin irritation. Therefore, first, the scabies should be suspected in infant or children with generalized pruritus or recent onset and the characteristic of eruption, where it added or accompanied with itching among the family members. At the same time, we must evaluate the person at risk. For example, if that person is, if that child is, if parents send that child at the nursery, and for example, at that nursery, there's any other child having that scabies, it would be higher risk for that children to be infected also. Second, in physical examination, as you can see, like the pictures I've shown before, and the scabies diagnosis is actually confirmed by the microscopic identification of the mite eggs or the scibilla. Scibilla is actually the feces of the mite, and where we can where we can find it by doing a technique known as a skin scraping technique. And another one is skin biopsy is rare. Skin scrap technique involving we place a drop of the mineral oil directly over the burrow on the skin. Then we superficially scraping longitudinally and laterally across the skin with the scalpel blade, as you can see in the picture. Next, the sample then placed on the microscopic slide and we examine, where the finding may appears like for this picture like female scabies mite with egg, and another one is egg containing developing larva, and also the scibilla, the fecal matter. As for the treatment, actually the treatment can be divided into pharmacological and non-pharmacological. Before we told the patient regarding the treatment, we must make sure that the parents know how to use the topical treatment, where the topical treatment must be applied to entire skin surface, but it has been controversial in treating in adult towards the face. As I mentioned before, the rashes, the lesion are rare in adult, but it is actually common in children, where including the face, the topical treatment must be applied because the transmission may also occur from the breastfeeding. At any time during the treatment, medication also should be reapplied if it is washed off, and we also need to treat the close physical contacts like the family members. These are the summarized doses and the side effects of common agents used in the scabies management. As for the first line therapy by the CDC, which is permethrin, Actually, the curative treatment for permethrin, curative treatment achieved by 12-hour overnight application of the permethrin 5% applied to the entire body. Because the permethrin is actually not effective against the egg, the treatment should be repeated 1 week later to kill any subsequently hatched larvae. And the side effect includes itching and burning, stinging sensation on application. And there are other agents that can be used. And this is the summarized treatment agent used in the specific consideration. Next, regarding the treatment of infection in scabies, actually secondary bacterial infection is a common complication in the scabies due to disruption of the epidermal barrier caused by the excoriation. Therefore, systemic antibiotic which covers the gram-positive organism for a minimum of 7 days must be given. The commonest one would be the Staphylococcus aureus, a Staphylococcus aureus that causing the secondary bacterial infection. And for the timing of the antibiotic commencement depends on the condition of the patient. It can be started concurrently with the scabicide or delayed for 48 hours to allow the partial healing of the erosion. Next would be the treatment of itchy in scabies, where we can give antihistamine like diphenhydramine, corticosteroid, and also emollient. And the non-pharmacological part would be the treatment for fomites, where the potentially contaminated clothes and bedding should be washed at high temperature, more than 50 degrees Celsius, or kept in the plastic bag for up to 72 hours. What I say is 72 hours because the mite they are separated from human host will die within this time period. And thus all the family members must use the fresh, clean bedding and clothing, and the use of the insecticidal powder or aerosol products should be reserved for the materials of object that cannot be washed. That's all for me.
Okay, thank you very much. So scabies is very, very common in children. And sometimes it's so difficult to treat scabies because of the hygienic practice not being practiced by families. You know, obviously, if you've got one child that has scabies, you need to treat the whole families. And also, you basically advise them for household cleaning as well. Because if you just treat them but not doing the household cleaning, then the scabies will come back again. And the most important thing about scabies, sometimes it's so difficult to, sometimes it's difficult, it's not straightforward to diagnose scabies. So we can't like, the differential will be infected eczema, it could be just cellulitis, or it could be impetigo and so on. So sometimes it's not straightforward to diagnose scabies, especially if the scabies are infected. Any question about scabies to your colleague? Semua macam nak accelerate. Yeah. Okay, fine. So let's go back. Let's go to next to other topic, which is Stevens-Johnson syndromes.
Assalamualaikum warahmatullahi wabarakatuh. My name is Ifa Mawada and I'll proceed with the last topic for dermatology seminar, which is Stevens-Johnson syndrome. Right. Next slide. This is my outline for this topic. Right. For your information, Stevens-Johnson syndrome is named for the physicians who first reported this kind of skin condition. Stevens-Johnson syndrome can be defined as severe and life-threatening type 4 hypersensitivity reaction that involves skin and mucous membrane. The characteristic of skin lesion involvement in Stevens-Johnson syndrome include epidermal detachment with less than 10% of body surface involved, while for the mucous membrane involvement, it defined as severe erosion of more than 2 mucosal surfaces with extensive necrosis of lips and mouth and purulent conjunctivitis. Next. Right, before we go in details about Stevens-Johnson syndrome, I would like to introduce to you other name of disease that I may use along this seminar, which is toxic epidermal necrolysis or PEN. SJS and PEN are actually considered to be the same skin condition but are along a spectrum of disease, whereby PEN, is the most severe form of SJS. It's just a variation of the same skin condition. Actually, there's also other diseases that are quite similar with SJS, which is erythema multiforme. Previously, erythema multiforme had been on the same spectrum of Stevens-Johnson syndrome and toxic epidermal necrolysis. But now, erythema multiforme is considered its own skin condition characterized by presence of typical target lesion like shown in this picture. SJS and PEN differ from each other by the percent of body surface area affected. So if less than 10% of body surface is affected, it's generally considered as Stevens-Johnson syndrome. If 10 to 30% is affected, it's considered overlap between SJS and PEN. And if more than 30% is affected, it's considered toxic epidermal necrolysis. Right. Next. Right. For the epidemiology, actually SJS is considered as a rare disease. So there have not much well epidemiological studies to determine the exact prevalence and incidence of this condition. But globally, the incidence of SJS is estimated ranging from 2 to 7 cases per million people per year. Based on estimated incidence in children, we can see that SJS is more common than PEN. SJS also can occur in patients of any age and is more common in women than in men with ratio of 2 to 1. SJS also serves morbidity to the patient such as having photophobia, burning eyes, visual impairment and blindness. Right, next. For the etiology, the medication or drugs are the leading trigger of Stevens-Johnson syndrome in both children and adults. The most frequent medication that can cause Stevens-Johnson syndrome are anticonvulsants such as phenobarbital, carbamazepine, and phenytoin, antibiotics, and also NSAID. Right? And then the sequelae of some bacterial and viral infection also can be the cause of SJS. For example, infection by Mycoplasma pneumoniae is the one of common trigger of SJS, particularly in children. Vaccination also can precipitate SJS, such as smallpox vaccination. For risk factor, HIV infection, underlying immunological disease or malignancy has higher risk. Patient with these comorbidities has higher risk to get Stevens-Johnson syndrome. The reason for this risk are not fully understood, but it may be because of exposure to multiple medication or immune dysregulation or presence of concomitant infection. And then for the genetic factor, actually there is several HLA types in human body that associated to the risk of drug-induced SJS. For example, HLA A29, HLA B12, HLA DR7 is associated with drug named sulfonamide. So meaning to say that if the patient have this type of HLA, they have higher risk to get SJS if the patient consumes sulfonamide. Okay, next. For the pathophysiology, it is suggested that SJS is due to cell-mediated cytotoxic reaction against keratinocyte that lead to massive apoptosis. Right? If the cell is healthy, we know that the cytotoxic T cell doesn't recognize the peptide as foreign and nothing happens. But in Stevens-Johnson syndrome, it is type 4 hypersensitivity reaction. So when drugs directly bind to HLA class 1 peptide, they can alter the peptide and recognize it as foreign. And then it can stimulate the immune system and result in clonal expansion of drug-specific cytotoxic T cell. Later on, it will kill the keratinocyte directly or indirectly through several pathways suggested, like shown in this picture. So this picture shows proposed pathogenic mechanism in SJS. If we look at the label B, the cytotoxic T cell will accumulate within the epidermal blister and then it will release perforin and granzyme B that can kill the keratinocyte. And if we look at the label D, The activation of CD8 plus T cell, NK cell, and NKT cell will secrete granulysin, which can induce keratinocyte death without the need for the cell contact. Right, so that the proposed pathogenic mechanism for SJS. Next, for the diagnosis, we can diagnose SJS clinically, and there are no universal accepted diagnostic criteria for SJS. There's also no diagnostic test for this disease. Histological finding may be helpful to support the diagnosis, but they are not specific and not diagnostic. Right, next. So we need to know the clinical presentation of this disease. From the definition, we know that SJS have the involvement of mucocutaneous lesion. This lesion actually preceded by 1 to 3 days of prodrome symptoms such as fever that often exceeding 39 degrees Celsius and also flu-like symptoms. There are also early symptoms of mucosal involvement such as photophobia, conjunctival itching or burning, and also pain on swallowing. Other symptoms that may present or include malaise, myalgia, and arthralgia. Right, next. Here we come to the main presentation of SJS, which is cutaneous lesion. The skin lesion typically begin with ill-defined, coalescing, erythematous macules with purpuric center. Right, we know that erythematous means redness. Macules are flat and not palpable lesion, and purpuric means purplish discoloration of skin, like shown in this picture. Besides of that, there's also atypical target lesion with darker center. Before this, I have mentioned that typical target lesion is the characteristic of erythema multiforme. Target lesion is actually a round skin lesion with 3 concentric color zones that have darker center, and then ring around this center is paler pink with edema, and the last zone is bright red ring. That's typical target lesion for erythema multiforme. But in SJS, it is atypical target lesion, which means the lesion just show 2 zones and indistinct border. And then the disease will progress, and as the disease progresses, the vesicles and bullae may form, and within this, the skin begins to slough. Next. Usually, this skin lesion will start on the face and thorax before spreading to other areas, and it is symmetrically distributed. The skin is often tender to touch. And then during physical examination, there will be positive Nikolsky sign, like shown in this slide. Positive Nikolsky sign means the epidermal layer easily slough off when pressure is applied to the affected area. Right. And then there's also presence of Esbo-Hansen sign, or also known as bullae spread sign, which shows lateral extension of bullae with pressure. And then next. For mucosal lesion, painful crust and erosion may occur on any mucosal surface, including oral, ocular, urogenital, and others mucosa. For oral mucosa, almost invariable involved in painful hemorrhagic erosion covered with grayish-white membrane. There's also stomatitis and mucositis, which can lead to impaired oral intake with consequent malnutrition and dehydration. For ocular involvement, the most common changes in eyes is a severe conjunctivitis with purulent discharge. Peroneal ulceration is frequent, and also anterior uveitis may occur. And then for urogenital involvement, urethritis will develop in up to 2/3 of patients and may lead to urinary retention. Genital erosion also frequent, and in female, vulvovaginal involvement may present. Other mucosal lesions include involvement of pharyngeal mucosa, tracheal, bronchial, and esophageal membrane, and also intestinal involvement. Right, next. For the complication, in severe cases with extensive skin detachment, acute complication may include massive loss of fluid through the denuded skin, electrolyte imbalance, and hypovolemic shock. Second one is patients with SJS are at higher risk of bacterial infection. That's it. and septic shock, most often caused by Staphylococcus aureus and Pseudomonas aeruginosa, and these are the main causes of death in this patient. Next is pulmonary complications such as pneumonia, interstitial pneumonitis, acute respiratory distress syndrome, and also acute respiratory failure. And the last one is gastrointestinal complication. It is a result from epithelial necrosis of esophagus, small bowel or colon. And the example of GIT complication are small bowel ulceration, colonic perforation, or small bowel intussusception. Next. For the severity of this disease, it depends on amount of skin detachment, meaning to say that the skin with positive nickel skin sign. The extent of this epidermal detachment should be estimated and recorded as percentage of body surface area involved. So to estimate how many percent body surface area are involved, there are several methods may be used, such as using Lund-Browder chart, rules of 9, and also palm method. For Lund-Browder chart, this chart is usually used to estimate percentage of burn skin involved in burn injury. So the number for specific part of body skin shown in this picture is refer to the percentage of body surface area involved. For example, in infant, if the skin detachment involve whole face, so the estimated body surface area is 9.5%. If it involve whole trunk of the body, means that 13% of body surface area involved, and so on. Right. And for the second method is using rules of 9. For rules of 9, head will represent 9% of total body surface area. For arm, it's 9%. If it's leg, 18%. And anterior and posterior trunk, each will represent 18% of total body surface area. Next method is palm method. For palm method, actually both children and adult surface of patient hand, including palm and finger, is correspond to 1% of total body surface area. Means that, okay, for Lund-Browder chart is recommended method in children, but if the burn is irregular or patchy, the palm method is more useful. Next. Okay, for investigation that I mentioned before, there's no specific investigation to diagnose SJS. But here are a list of investigation that can be done to rule out other differential diagnosis or look for complication of disease. For skin biopsy, the finding may show extensive eosinophilic necrosis of epidermis with suprabasal cleavage pain, but again, this finding is not specific. In renal profile, there may be elevated of blood urea, hyperkalemia, and creatinine. And then for full blood count, there may be presence of hematologic abnormalities, particularly anemia and lymphopenia. And then for liver function test, there will be abnormalities that depends on toxicity of the medication that precipitated SJS or TEN. For ultra blood gas, it may help to determine the patient's clinical respiratory status, as one of the complications of SJS is mucosal involvement of upper and lower respiratory tract. And then for blood culture and sensitivity, it's necessarily to rule out other infection. In children, the serology or PCR for Mycoplasma pneumonia infection should be obtained as it is common in children. And then last, for chest radiograph, it should be obtained in all patients due to high risk of pneumonia and interstitial pneumonitis. Next. For management, we can divide it into supportive care, specific treatment, monitoring, and prevent complications. For supportive care, we should admit the patient to isolation room where possible. And then the patient also may need IV fluid resuscitation for shock. And then it is also important to have good nursing care. And then the patient may use air fluidized bed to avoid bed sore. Adequate nutrition also important, but since SJS patient may have GI mucosal complication, adequate nutrition may be given via nasogastric tube, IV line, or parenteral nutrition. And then for specific treatment, it is vital to eliminate the suspected offending drug, first, and then give IV immunoglobulin at a dose of 0.4 gram per kg per day for 5 days. This IV immunoglobulin may helpful to arrest the progression of the disease and helps to complete reepithelialization of tissue. Alright, in monitoring, maintenance of body temperature is important to avoid excessive cooling or overheating. And then careful monitoring of fluid and electrolyte can be done by measuring blood pressure and pulse rate. And then we also need to monitor intake and output chart by measuring daily weighting and also renal profile result. And last one, to prevent complication, it's important to treat infection with appropriate antibiotics and dressing properly for skin care. Then for eye care management, the patient need to do frequent eye assessment and use of antibiotic or antiseptic eye drop 2 hourly. And the last one for oral care, we need to take care of good oral hygiene. Okay. Okay, this is my reference. That's all for me.
Okay, thank you very much. Have you guys got any question about Stevens-Johnson syndrome? So sometimes people don't realize they've seen a Stevens-Johnson syndrome, but if you got somebody who has a skin lesion with mucosal involvement, red eyes, sometimes they can have red urine as well of frank hematuria. Then think about possible interaction or possible reaction to medication that you're given. And obviously, if they have any infection also can cause that as well. So antibiotics also can cause Stevens-Johnson syndrome. Anti-epileptic medication, mainly the carbamazepine, the phenytoin, phenobarbital, also can cause that as well, but not as high as carbamazepine. There is a specific gene that you need to test, HLA-B1502, I think. You need to test for this genetics before you start patient on carbamazepine. It's mainly more common in Chinese population rather than Malay population. But obviously, it's still possible that it could happen in Malay population anyway. Stevens-Johnson syndrome is mainly clinical diagnosis. People say you can confirm then, or gold standard confirmation is by doing the skin biopsy. But if they are unwell, very unwell, you need to treat them urgently by removing the triggers, and also make sure that the input output fluid need to be balanced. You don't want them to be hypovolemic shock. Normally we give IVIG. Some of us might give IV methylprednisolone for the treatment, but the mainstay of treatment will be IVIG. And obviously, optimize the nutrition as well. It sometimes also can cause renal impairment quite significantly, because if the skin lesions got worse, and sometimes it can go to fasciitis, destroy your muscles. The patient will end up with renal impairment. So at SJS, you really want to make sure that you put them into the intensive care monitoring, because they can deteriorate quite significantly, quite fast. Okay, I think that's all for the dermatology. Any question you want to ask about these 4 topics before we move on? Ada question kat sini. So, possibilities for us to mistake this with SLE. Well, I would say yes. Because sometimes you might be worried that the SLE itself, the Stephen Johnson itself is a manifestation of SLE. So I would be thinking about SLE at some point as well. If I got a patient that clinically looks like SGS, you give them IVIG anyway, but it could be the presentation or the first presentation of SLE that looks like SGS. So I'm not really surprised if some of us would think about SLE at the same time. But obviously, if it happened to a girl and you think that this is SGS, you need in the back of your mind, you probably need to look for autoimmune conditions because because SGS could be first manifestation of the SLE. So you need to send for ENA screening, anti-double strand DNAs, antibodies. So if that's come back positive, then you need to treat them as SLE. You need to treat them after that for SLE. So there's no such as definitive sign or symptoms to defer them. I wouldn't say so because it's not that easy. Because there would be overlapping signs and symptoms between SLE and SGS. Okay. Okay, fine. So we got 5 more topics for oncology, so we need to spin through this quite quickly. All right, so carry on.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So now we from seminar group 12 will be presenting about seminar oncology. So next, this is our topic for the presentation today. So the topics are leukemia, lymphoma, neuroblastoma, nephroblastoma, and also brain tumor. So first, I will present about leukemia. So my name is Muhammad Naufal bin Amin Najib. So first, what is the definition of the leukemia? So leukemia is a group of disorders characterized by the accumulation of malignant white cell in the bone marrow and also in the blood. So this malignant white cell will cause symptom of bone marrow failure like anemia, neutropenia, and also thrombocytopenia. And also it also can cause infiltration of organ like spleen, liver, lymph nodes, meninges, brain, skin, and testes. Okay. So leukemia is the most common malignant neoplasm in childhood, which is 31% of the all malignant neoplasm cases. So this is the division of the epidemiology of childhood leukemia. The most prevalent is acute lymphoblastic leukemia with 77%, and then following by acute myeloid leukemia by 11%. And next, chronic myeloid leukemia and also juvenile myelomonocytic leukemia, which is very rare. Okay. Next I will present about the factors. So actually the exact cause of the leukemia is still unknown, but there is some factor that associate with this leukemia. So the first one is genetic factor. is like translocation, just like Philadelphia chromosome, and also there is underlying or background genetic syndrome or disease like Down syndrome and Fanconi anemia. So the next factor is environmental factor like ionizing radiation and also chemical exposure like chemotherapy. So this factor can cause genetic damage, which is believed to involve and which is can result in increased proliferation, reduce apoptosis, block the cellular differentiation, and can cause the accumulation of the blast cell, which is the immature white cell in the bone marrow. Okay, so today, so now I will present the only two example of leukemia, which is the acute lymphoblastic leukemia and also acute myeloid leukemia, as it is the most common in pediatric. So first, the acute lymphoblastic leukemia. First, the definition, which is acute lymphoblastic leukemia (OALL) is an accumulation of lymphoblasts in the bone marrow. It is the lymphoblast is arise from the early cells in the lymphoid series. So ALL has a genetic association with Down syndrome, hyperdiploidy, and also translocation. So next, it is the classification, the FAB, which is French American British classification of lymphoblastic leukemia. This is the classification is based on the morphology of the lymphoblast. So the first one is L1, the L1 class L1, which is the small lymphoblast and little cytoplasm, and then L2, the larger and pleomorphic lymphoblast, and there is more cytoplasm, and lastly the L3, which is there is cytoplasmic vacuoles, and also finely stippled nuclear chromatin. Okay, next, this is the classification of ALL according to WHO, and this classification is based on the underlying genetic defect. So that we can see that there is example like translocation, 9 to 22, and others lah, the underlying genetic defect. Okay. So next I will present about the clinical features of the ALL. So just like I said before in the definition, uh, the the lymphoblast will have the clinical features because of bone marrow failure and also organ infiltration. So the clinical feature is based on the pathogenesis that I have stated before. So the first one, in general, there will be malaise and also anorexia. And for bone marrow, there will be anemia, which is will be presented with pallor and also lethargy. And then there will also thrombocytopenia, and the patient will be presented with bruising, petechiae, and also nose or gum bleeding. And next, the patient also can have neutropenia, and the patient will be presented with infection, fever, and also mouth ulcer. And the last one, the patient will be presented with bone pain, and the patient will have limping gait. There is abnormality during walking. Okay, next, there will also the organ infiltration. The the first one is the reticuloendothelial system. There will be hepatosplenomegaly, lymphadenopathy, and also superior mediastinal obstruction, which is there is the infiltration of the thymus that will can cause obstruction at the surrounding organ. And also the last one is the other organ that can involve in this patient. First one is CNS. The patient can present it with headache, vomiting, convulsion, and also nerve palsy. The patient also can have infiltration at the testis and can cause testicular enlargement. And also the lymphoblast also can infiltrate to kidney, which is cause acute renal failure. So next, this is the clinical the picture for the clinical feature. And the first one we can look, there is marked cervical lymphadenopathy. And the second one we can look, there is testicular swelling and erythema on the left side of the left testis, caused left scrotum caused by testicular enlargement. Okay. So next, in terms of investigation, for investigation, we can do complete blood count. Complete blood count as the patient will have anemia, which is it is normochromic normocytic. And also next for the for white cell count, it can be increased, normal or reduced, and the platelet will be reduced, which is thrombocytopenia. And in the blood film, the blast may be present in the blood film. Next one is in bone marrow examination. There must be a blast cell present in the bone marrow, which is must be more than 20% infiltration at the bone marrow. And next, we can also do chest X-ray to check for any mediastinal mass. Because in T lymphocyte ALL, we can have the mediastinal mass. And next, we also can do CSF examination. In the CSF examination, we can see blast cell if there is involvement to the CSF. And next, we can do the renal function and uric acid, because if there is involvement to the kidney, the renal function will be impaired, and also there will be increase in uric acid. And also the last one is the special classification test, which is we want to classify the leukemia based on the classification that I had stated before, which is classify in terms of the morphology, and also in terms of the phenotype, and in terms of the phenotype, and also molecular or genetic defect. So we can do chromosomal analysis, and also immunocytochemistry and immunophenotyping. So next, this is as we can look from the chest X-ray here. In the first one, is the left side. There is large mediastinal mass caused by the thymic enlargement. And then the right side, we can look after the chest X-ray of after 1 week of therapy. We can look at the mass has been resolved. Okay. Okay, this is the examination, the bone marrow examination from the bone marrow examination. We can look the morphology, the cytochemistry of the acute lymphoblastic leukemia. So for the first one, we can look, there is lymphoblast showing scanty cytoplasm without granules. And the second one, we can see the lymphoblasts are large and heterogeneous with abundant cytoplasm. The third one, we can see cytoplasmic vacuolation. And the last one, we can this is the immunofluorescent, direct immunofluorescence, which reveal the nuclear terminal deoxynucleotide transferase. So the A is from the classification that I stated before is L1, the B is L2, and the C is L3. Okay, next, this is in terms of management. So this is the specific treatment for leukemia. So generally, the management or the specific treatment for leukemia can be consists of induction of remission, which is it aimed to kill rapidly the tumor cells. And the example of the medication is like vincristine, steroid, and also the others. Okay. And then the second one is the consolidation, which is to bring down the tumor burden to very low level. And then there is intensification, which is to clear the submicroscopic or the minimal residual of minimal residual of disease. And also there will be the maintenance of the specific treatment or the chemotherapy. And you all can read the example of the medication in this management. Okay, next this is the this is the description of the management that I have stated before. Okay, this is the prognosis of ALL. So for good prognosis, I have to be low initial in white cell count, female, 2 to 10 years age, less than 4 weeks to remission, translocation of gene 12 and 21, hyperdiploidy, and also CALOL1, and the classification of the ALL. So for poor prognosis, the initial white cell count is high, the patient is male, the age is less than 2 years or more than 10 years, and then there is more than 4 weeks to remission. The genetic defect is translocation 922 and also translocation 411, and also there is hypoploidy and CNS involvement in the patient. Okay, so next I will present about the acute myeloid leukemia, which is the second most common of leukemia in pediatric. So the definition of acute myeloid leukemia is the immature cell that arise from a pluripotent cell or myeloid progenital committed to erythroid granulocyte, monocytic, or megakaryocyte line. So AML is associated with Down syndrome, aplastic anemia, Fanconi anemia, and also it also associated with previous chemotherapy. So this is the classification of AML based on the FAB system. It is just like the ALL. It is classified based on the morphology of the blood cell, which is the M0 is undifferentiated, M1 myeloblastic and also no maturation, M2 myeloblastic and some maturation, M3 acute promyelocytic, M4 myelomonocytic, M5 monocytic, M6 erythroleukemia, and M7 megakaryoblasttic. And this table have stated the some features and also the prognosis of each of the classification. So in the for M2 and M3 and 4, the prognosis is good, and for the M6 the prognosis is poor. Okay, next for clinical feature, actually the clinical features are actually as similar with the ALL. So the first one is bone marrow failure. Like ALL, there will be anemia, white cell count can be normal or decrease or increase, and also there will be thrombocytopenia and also bone pain. In AML also, it can be gum hypertrophy, especially in M4 and also M5. The patient also can present with DIC, disseminated intravascular coagulopathy, which is in M3 type of AML. And also the patient also can have chloroma. Chloroma is a localized mass of leukemic cell that can be present in the skin and also retroorbital. Okay, next for investigation, it is same as ALL. I have stated before, and in the bone marrow, it must contain more than 30% blood cell, and it also may contain aurochs, which is the features of AML in blast cell in AML. So the first one we can see there is this blast cell without differentiation, and we can see it as it show aurat as you can see there. And for the next picture, it is M3 blast cell which contain prominent granule with multiple aurats. Okay, this is in term of management. For it, just like the ALL, there will be the induction of remission, which is to induction of remission, which is to kill rapidly the tumor cell by the chemotherapy, and also there will be consolidation, which is to bring down the tumor burden to very low level, and also there will be further consolidation in the management. Okay, next, this is the summary of the clinical features in childhood leukemia. So I think that's all.
Okay, so acute leukemia is one of the commonest oncologic hematological disorder in children, mainly ALL. GML is quite rare. I'm not saying it's very rare, it's quite rare. And obviously the next one is AML. The difference between leukemia and also lymphoma, I think your colleague will answer after this. But the main thing about any kind of tumors, you want to be very sure that you should mention about, we call it hemolytic syndrome, acute hemolytic syndrome, where your tumors can lyse very rapidly and can cause renal failure because of that. So very important that you mention that, especially in leukemia, the higher your white cells, the high risk of developing acute tumor lytic syndrome. You mentioned about the mediastinum mass. So as soon as you start steroids, which is dexamethasone, the mediastinum mass can rapidly shrink within 48 hours after starting steroid medication. Not even chemotherapy, just a steroid medication. It will reduce the mediastinum mass very rapidly. Okay, any question to your colleague before we move to lymphoma? Okay. If there's no question, then we go for lymphoma then.
Can you guys hear me? Yes. So
Yes.
today I will be presenting about lymphoma. My name is Ahmad Faiz bin Abdul Rahman. Next. Next slide. Next slide, please. So this is my contents of slide. So first, we have next slide. We go to the definition. First, lymphoma can be defined, generally defined as cancer that arise from cells of immune system, mainly lymphocyte. According to textbook reference, it is a malignant tumor. It is a malignant tumor of lymph node and extranodal tissue. Previously, during basic medical sciences, we have learned about the lymphatic system and its function. It is located all over our body and connected by the lymphatic vessels. It is consists of lymphoid tissue, lymphocyte, and lymphatic fluid. And the figures that are inserted in the slide shows that the site of lymph nodes in our body and its vessel networks. Next slide. So then we proceed to epidemiology. So based on National Cancer Registry report from 2012 to 2016, lymphoma is one of the common cancers among children and adolescents. Okay. As for Hodgkin lymphoma, in worldwide, it is approximately 2 to 4 new cases per 100,000 children in a year, and it has a bimodal age distribution, which the first peak at 15 to 25 years old, and the second peak over 50 years old. and it is predominantly by male. For non-Hodgkin lymphoma, it is contribute for 60% of lymphoma cases in children, and it is a second most common malignancy in age 15 to 35 years old. Usually in pediatric, it is higher in grade. So next. For the next is classification. Lymphoma can be divided into two types, which are Hodgkin lymphoma and non-Hodgkin lymphoma. Each can be further classified into types. For generally, Hodgkin can be divided into classical Hodgkin lymphoma, which later divided into 4 subtypes, and nodular lymphocyte predominant Hodgkin lymphoma, which are not stated in this slide. So brief about classical Hodgkin lymphoma, we have nodular sclerosing, which is characteristic by nodular pattern and lacuna type Ritz-Sternberg cells. So I believe that all of you know what is Ritz-Sternberg cells is. So this is the nodular sclerosing Hodgkin lymphoma is the most common type of classical Hodgkin lymphoma in all ages. Next is mixed cellularity. This is more common in young children. And then we have lymphocyte rich and lymphocyte depleted Hodgkin lymphoma, which are rare. So then non-Hodgkin lymphoma has a lot of subtypes, but in this slide, I listed the common types in pediatrics, which are lymphoblastic lymphoma, diffuse large B-cell lymphoma, anaplastic large cell lymphoma, and also Burkitt lymphoma. Next. After that, let's talk briefly about the causes and the risk factor of lymphoma. Here I listed all the causes of both Hodgkin and non-Hodgkin lymphoma. First, infections. There are many organisms that contribute to lymphoma. Epstein-Barr virus is common cause of Hodgkin lymphoma, followed by others such as human herpes virus 6, cytomegalovirus, hepatitis virus, and bacteria such as H. pylori and others. Other than that, other causes we can have chromosomal mutation. Mainly translocation is the one of the cause that, especially in Burkitt lymphoma, they are present of translocation at 8 to 14, which are responsible for c-MYC gene that are responsible for cell cycle regulation. And then we have immunodeficiency states, whether inherited or acquired, can predispose also someone to get lymphoma. For example, in patients who have severe combined immunodeficiency and visceral outreach immunodeficiency, and also patients who have HIV and organ transplantation, also at risk of developing lymphoma. Genetics also have role in developing lymphoma. Study shows that patients with HLA-DRB1 and HLA-DQB1 is susceptible for getting lymphoma. And also, environmental factors also one of the causes. For example, such as pesticide exposure and radiation. Next. Next, we go to the pathogenesis and clinical findings of lymphoma. So this figure is the simplified version of the pathogenesis and also the clinical findings. So for Hodgkin lymphoma, as I said before, the common cause of Hodgkin lymphoma is Epstein-Barr virus. So this will cause generation of Ritz-Sternberg cells. The Ritz-Sternberg cells can be seen at the figures, the cells figures there. That is Ritz-Sternberg cells, and when the Ritz-Sternberg cell is generated, and then it will accumulate within the lymphoid tissues and secrete cytokines. Based from this mechanism, it will cause many symptoms such as B symptoms, such as weight loss, malaise, fever and chills, and night sweats. And also it can cause pruritus, and it said that it caused by cytokine release near the skin nerve. And then after the Ritz-Sternberg cell accumulate, it will secrete the cytokine, right? So the cytokine will attract other reactive white blood cells such as neutrophil, lymphocytes, eosinophil, and monocyte, and then it then form the bulk of the lymph node tumor. As the cells accumulate, it will enlarge the lymph nodes, and from the enlargement of lymph nodes, and then it will give rise to the most clinical finding in lymphoma, which are lymphadenopathy, which are painless and rubbery in consistency. As the lymph node enlarge and progressively enlarge, it will exert the mass effect against adjacent organ, such as it will exert mass effect against heart and lung, and will cause chest pain and dyspnea, it will exert effect to the GI tract and cause abdominal pain, and exert effect against esophagus or oropharynx, and then will lead to dysphagia. After that, the reactive white blood cell will further support the red stem blood cell accumulation, and then the red stem blood cell will typically spread in an orderly way to anatomically adjacent lymph tissue outside of lymph nodes. So the common extranodal tissue that will be involved is the spleen, liver, and the bone marrow. So splenomegaly, it can cause splenomegaly and rarely hepatomegaly and bone marrow infiltration. So next for pathogenesis of non-Hodgkin lymphoma and its clinical finding. So in non-Hodgkin lymphoma, it will have the common cause of non-Hodgkin lymphoma is chromosomal mutation. So from the chromosomal mutation, it will cause genome damage that are affecting the proto-oncogenes and the signal translation factors that are responsible for the cell cycle pathway. So when the cell cycle pathway is broken or is damaged, there are increased monoclonal proliferation of lymphoid tissue, mainly the B cell, the T cell, and the NK cells. So these cells will accumulate in the lymphoid tissue, which are the blood, spleen, lymph nodes, and also the mucosa associated lymphoid tissue. And then from this accumulation, it will give rise to this to the sign and symptom. So first, when it accumulates in the lymph nodes, the lymph node will become enlarged and give rise to lymph adenopathy, same to the Hodgkin lymphoma. And after that, if the lymph nodes become progressively enlarged, it will exert a mass effect, same as a Hodgkin lymphoma. It will exert the mass effect against the adjacent organs, such as the heart, the GI tract, and also the heart and GI tract. And also when the mass is enlarged, very enlarged, it will also cause vascular obstruction, mainly the superior vena cava, and give rise to superior vena cava syndrome. And then the malignant cells also will accumulate in the spleen and also cause splenomegaly, and this malignant cell also will undergo rapid destruction or rapid spontaneous breakdown, and then it will cause tumor lysis syndrome. And this tumor lysis syndrome is manifest as in investigation, such as hyperuricemia, hyperkalemia, and hypoglycemia. And then next, the malignant cell will accumulate in disorderly way, and also it will metastasize to other extranodal tissue. So the malignant cell will infiltrate into the bone marrow, and it will cause decrease in hematopoiesis. So this decrease in hematopoiesis will give rise to cytopenia, which are anemia, and give rise to pallor and fatigue, thrombocytopenia, and leukopenia. Other metastasized site is like liver, GI tract, bone, kidney, and also testis, and will give rise to the clinical sign and symptom. Next. After that, I will briefly explain about the staging of lymphoma. First, for Hodgkin lymphoma, so we use Ann Arbor staging. So Ann Arbor staging has 4 stages, which are the stage 1, it involves single lymph node region. The second stage, more than 2 lymph node region in the same site of the diaphragm. Third stage, lymph node region both side of the diaphragm, plus minus spleen. The fourth stage is the simultaneous involvement of extra lymphatic organs such as liver and bone marrow. And this stage also have modifying features such as A, B, E, and X. So A is asymptomatic, B is the presence of B symptom, which are unexplained fever more than 38 degrees Celsius, night sweat, and loss of weight more than 10% of body weight in 6 months. So E is involvement of extranodal site. X is bulky disease, where the mass is more than 10 centimeter and increase in thoracic diameter more than 0.33. After that, next, for non-Hodgkin lymphoma, we use International Pediatric Non-Hodgkin Lymphoma Staging System, ITNHLSS, also known as Murphy Staging System. So this staging system is reflects more on the tumor volume rather than degree of spread from the primary site. It also consists of 4 stages, and you guys can read it. So this, next slide. So these are the investigation that we done when suspecting lymphoma. So first, we can do blood investigation. For blood investigation, we can do full blood count. Full blood count will we can look for anemia and also pancytopenia if there are bone marrow infiltration, and also erythrocyte sedimentation rate. Yeah, as it is a general marker of inflammation, and also serum lactate dehydrogenase and serum ferritin. These two component is one of prognosis factors in factors that determining the prognosis of lymphoma. So if these two component is raised, that means that it has a poor prognosis. And then we can do lymph nodes investigation. For lymph node investigation, we have excisional lymph node biopsy and fine needle aspiration biopsy. Fine needle aspiration cytology. So for these two is mainly for histologic classification that we can classify it into classify it lah. And then we can do bone marrow biopsy to look for bone marrow involvement, as it is important also in staging. And also we can do imaging such as chest radiograph to look for any mediastinal mass, CT scan of neck, chest, abdomen, and pelvis to look. It is important to look for the extent of the disease and for staging, and also positive PET scan, which are used for prognostic value. The test may include serology analysis for Epstein-Barr virus, cytomegalovirus, and also HIV. Next slide. So this is an overview. This is the figure for the chest X-ray. It shows anterior mediastinal mass with, in the patient with Hodgkin lymphoma, and the progression after 2 months of chemotherapy. Next slide. So next slide, a brief about treatment of lymphoma. For Hodgkin lymphoma, we use combined chemotherapy and radiation therapy. So the common combination of chemotherapy used is ABVD, which are doxorubicin, adriamycin, bleomycin, vinblastine, or dacarbazine. And also we can use COPP, which are cyclophosphamide, oncovin, prednisone, and procarbazine. As for non-Hodgkin lymphoma, it is depend on grade of malignancy. In high-grade non-Hodgkin lymphoma that usually seen in children, it is treated with multi-agent chemotherapy and or immunotherapy. Surgical intervention is done only to obtain tissue for diagnosis, and stem cell transplantation is used in relapse treatment for both Hodgkin lymphoma and also non-Hodgkin lymphoma. In non-Hodgkin lymphoma, as stated earlier, in the pathogenesis of next slide. In for non-Hodgkin, as I said earlier, in the pathogenesis slide, it can cause tumor lysis syndrome. So tumor lysis syndrome is a rapid destruction of tumor cell resulting in release of intracellular ions and metabolic byproducts to the bloodstream. It can cause hyperkalemia, hyperuricemia, hyperphosphatemia, and hypoglycemia. So if the tumor lysis syndrome happen, it is required vigorous intravenous fluid administration, frequent monitoring, and administration of allopurinol, which is xanthine oxidase inhibitor, to prevent or correct the high uric acid in blood. So lastly, for the prognosis for both Hodgkin lymphoma and non-Hodgkin lymphoma is good. And it depends on the stage, the presence of these symptoms, and the bulky nodal disease. So overall survival for both is more than 90% approximately for both lymphomas. So by all that means, the goal of treatment nowadays is to reduce the long-term complication of the therapy, such as growth retardation, cardiotoxicity, neurotoxicity, and many else, and to increase the efficiency of the care at the same time. I think that's all.
So what is the difference between lymphoma dengan leukemia?
From what I've read, the difference between lymphoma and leukemia, the lymphoma is generally manifest as extranodal disease, which dia is more in apa tadi? Dia bulky extramedullary, so dia ada it consists of enlargement of the lymph node for leukemia, from what I've read. And from the for the bone marrow investigation, acute leukemia, as Naufal said, is defined as blast count more than 25%. In lymphoma, the extramedullary tumor accompanied by marrow involvement below 25% is stage 4 lymphoma.
Okay, fine. So basically, leukemia also can have extranodal enlargement as well. Lymphoma is mainly extranodal lymph node enlargement. So the only difference between leukemia and lymphoma is the bone marrow. So if you got somebody who have very big lymph nodes in the neck ke apa, tapi dia punya bone marrow dia blast saja 40%, then that's leukemia. Okay, so and if somebody got not very big lymph nodes, but when you do bone marrow, the bone marrow blast less than 25%, then that's going to be lymphoma. Okay, so that's the difference between leukemia and lymphoma is the blast cells in the bone marrow. Okay, so there is a very fine line differentiation between lymphoma and leukemia, which is the percentage of blast cells in the bone marrow. Okay, you can have a very big lymph nodes in the abdomen, tapi tengok dia punya bone marrow dia blast cell maybe 40%. Then that's going to be leukemia rather than lymphoma. Any other question for your colleague? Okay, so since there's not many questions here, then we can go straight to this next topics.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Everyone can hear me? Right. My name is Dr Azamin and I'll be presenting about neuroblastoma. So first of all, let's define first what's the meaning of neuroblastoma. Next slide. All right. So the introduction. Neuroblastomas are embryonal cancers. Basically, neuroblastoma we refer to as those cells that derive from the neural crest in the embryonic stage. So it involves embryonic cancers of the peripheral sympathetic nervous systems. It can be adrenal medulla or any ganglions within the sympathetic nervous systems. The term neuroblastic includes tumors of the sympathetic ganglia and adrenal medulla that are derived from primordial neural crests populating these sites. Basically, the neuroblastoma is the tumor that can have in any sites within the peripheral sympathetic nervous system. Okay, next. So the epidemiology is that neuroblastoma is the most common extracranial solid tumor in children, and second most after brain tumors that accounts for more than 15% of mortality from cancer in children due to usually late diagnosis, because after this we'll discuss why the delay in diagnosis. Next. The pathology is, as been mentioned before, derived from primordial neural crest. It can ranging from tumors with primarily undifferentiated to differentiated cells, and also maturing Schwannian stroma with ganglion cells. It can be in the form of neuroblastoma, or ganglioneuroblastoma, or ganglioneuroma. So it is spectrums of disease or spectrums of types in neuroblastoma. Okay, next. The pathogenesis, the etiology in most cases remain unknown, but they have found the connection in the mutations of genes of proto-oncogenes and also tumor suppressor genes of ALK and also FOX2B genes been linked to the familial predispositions. Most of the cases are sporadic in nature, however, 1 to 2% are familial. Means that they are related to genetic predisposition in the families. Right, so, and also the BARD1 gene is also identified as a major genetic contributor to neuroblastoma risk. However, the thing is that the main cause or the main reason for the overproliferation of abnormal proliferation, abnormal growth of the neuroblastoma is from the mutation of the genes. And also they found an association of the parents who are exposed to chemical such as farming or work in chemical factories, so on and so forth. So next. It been found that the neuroblastoma have a strong association with certain syndromes or diseases. In general, it's related to any other neural crash disorders such as Hirschsprung's disease, central hypoventilation syndrome. There are a list of syndromes that are related to neuroblastoma. So if we found patient with any syndrome related to neural crash disorders, and found presented with mass or any spinal compressions presentation. So neuroblastoma is one of the differential diagnoses that we can think of. So next. The pathophysiology, as we said that, as we all know, that the definition basically any growth in any site of sympathetic nervous system tissue. So the pathophysiology is that it grows in whether in adrenal glands or paraspinal sympathetic ganglia. It can be in any part of sympathetic ganglia. So most half of the cases is in adrenal glands, but the remainder is originate in the paraspinal sympathetic ganglia, which can present it with different or varieties of clinical presentation. And also it can have metastatic spread for children more than 1 year old through local invasion or distant lymphatic or hematogenous routes. Common metastatic sites, regional or distant lymph nodes that can come with lymphadenopathy, long bones and skull, which can cause periorbital ecchymosis, bone marrow that can cause cytopenia, liver that can cause liver involvement, liver enlargement, and skin lesions. So less than 3% of lung and brain metastasis. So it's rarely to metastasize to brain and lung. And next. As for clinical features, the signs and symptoms of neuroblastoma reflect the tumor site and extent of the disease and may mimic other disorders. So the condition or the clinical manifestation from the neuroblastomas can mimic other disorders that lack of specificity results in a delayed diagnosis. And that's the reason why it causes more than 50% of death in children. So depending on either it's a localized disease or metastatic diseases, so depend on the locations or the extents of the spread of the tumor cells. So localized disease can manifest as any symptomatic mass or can cause symptoms from mass effects such as compressions syndrome, and in certain cases can result in spinal cord compression that can presented with bowel obstruction or superior vena cava syndrome. Next. All right, so it can also present associated with neurologic signs and symptoms, such as if the tumor growth in superior cervical ganglion, it will presented with Horner syndrome, which is meiosis of ptosis of the eyes or anhidrosis. Paraspinal neuroblastoma tumors can invade neural foramina in the brain, if you can see it from the image. So it can present it with rapid, uncontrollable jerking eyes and body movements, poor coordination and cognitive dysfunction. And some paraneoplastic syndrome can cause produce catecholamines that can cause increased sweating and hypertension, basically increase in sympathetic activities. Next. extensive tumors can also experience tumorisis and disseminated intravascular coagulopathy. The metastatic disease can cause a variety of signs and symptoms, basically as a result from the presence of chemokines in the systemic circulation that can lead to patient presented with fever, irritability, failure to thrive, bone pain in case of any bone metastasize, blue subcutaneous nodules, orbital proptosis, and periorbital ecchymosis that have been mentioned before. If there is a metastasize to the base of the skull. In general, the presentation can be too abstract and non-specific to the diseases. However, we should think of neuroblastoma as one of differential diagnosis because it can overlap with other diseases in terms of clinical manifestations. Okay, next. For diagnosis, at first, usually the neuroblastoma usually discovered as a single mass or multiple masses on X-ray, CT, or MRI. So basically, imaging study to know the locations, to know the sites, and tumor markers from urine sample, which is homovanillic acid or vinyl mandelic acid, HVA or VMA, in the urine samples, which both of these are metabolites of catecholamines. As we all know that when there is increase in sympathetic nervous system, increase in catecholamines, which is epinephrine and norepinephrine. So the metabolites from the degenerations of these two catecholamines resulted in increased HVA and VMA in the system. So it will be secreted into the urine. So the tumor markers will be there will be increase in HVA and VMA. But the important part is the pathologic diagnosis. The only way to diagnose this condition is established from tumor tissue obtained from biopsy from the mass. Okay, next. And these are the imaging studies. You can see from the sections of CT scan, also X-ray. Next. And the most important part in diagnosis and also in management is to use the International Neuroblastoma Risk Group, INRG, or staging system, INSS, is used to stage patients with neuroblastoma. Basically, it's from the image, from the extent of imaging, a diagnosis, and image-defined risk factors. Basically, image-defined risk factors is a form of a groups of parameters that may use to evaluate the extension and also the severity of the neuroblastoma. So L1, or previously referred to as stage 1, localized and confined to one body compartment. L2, stage 2 and 3, localized tumors with presence of IDRFs. M, stage 4, referred to metastasized to bone marrow, liver, distant lymph nodes, and other organs. Stage 4S, or in current in now we use as MS, less than 18 months old patient with dissemination to liver, skin, bone marrow without bone involvement, and with primary tumor that will otherwise be staged as L1 or L2. So basically, the over differentiation will be referred to as MS. Right. So next. So the prognosis, in terms of prognosis of the patient with neuroblastoma, it all depends on a prognostic importance of certain genetic characteristics, which is first one is amplification of the MYCN, proto-oncogene, and also tumor cell DNA content, or ploidy. Basically, the tumor cell, the content of the DNA, we can extract, and also we do genetic studies, and also when we know the genetic backups, then we can tell the prognosis of the patient. All of these things, the patient age, the extent or the staging, and also the genetic amplification of the MOS and proto-oncogene, also, or the genetic makeup of DNA, tumor cell DNA, is used to evaluate the risk group of the classification for risk group for neuroblastoma. So you can read about this after this. Next. So in terms of management, as been said before, patient age, tumor staging, combined with cytogenetic and molecular features of the tumor cells were used to determine risk group for management. So after this, I'll show you the the table for the risk group. So first, the treatment for low risk. Basically, the management of patient with neuroblastoma is multimodal in terms of its management. It can be surgical, medications, and chemotherapy, and also radiation therapy. For treatment for low risk, typically includes surgery for stage stage L1 and L2, and observation for asymptomatic stage MS. Basically, cure rates are generally more than 90%. The thing is that the more differentiated the neuroblastoma tumor cells, much easier for it to be managed or to have a high cure rates. In terms of spinal cord compression, at diagnosis may require urgent treatment to avoid neurologic damage, because as we know that spinal cord compression, if not being treated quickly, it can cause permanent disability to the patient. For intermediate risk, include surgery, chemotherapy, and in some cases radiation therapy. For high-risk neuroblastoma that have had poor long-term survival rates between 25 and 35% with treatment, includes intensive chemotherapy, high-dose chemotherapy with autologous stem cell rescue, surgery, radiation, and 13-cis retinoic acid. So next. These are the international risk group pre-treatment classification scheme. So by following this table, we can classify the patient no matter what the age or what the presentation that they came, based on the result from the investigation that we run on the patient. We can segregate the patient in the proper risk group and manage them properly, depending on which group they are being classified into. So this is the main thing that need to be focused on when it comes to management. I think next, I think that's all. Okay, right. So that's all for presentation for neuroblastoma. It's pretty direct, but that's all. Okay, thank you.
Right, so as your colleague says, it's pretty direct. So all of you will become oncologists by now. Any question for this topic? So it's a neuroblastoma. The classification scheme just now is try to stratify which one is low risk, which one is high risk. The low risk will go to surgery first before chemotherapies, and some of them probably not needing chemotherapy, probably just surgery. But I would say most of them, yeah, low grade tumors, it will go to surgery plus minus a bit of chemotherapy. The high risk will probably go for chemo first plus surgery plus more chemo, and some of them might need radiotherapy as well, depending on the size of the tumor. But generally, neuroblastoma is a disease of childhood. You don't really see neuroblastoma in teenagers or adults. The thing is, it's sometimes they come very late because most of the child probably not have any symptom apart from distended abdomen. So that's the main thing about neuroblastoma. So sometimes they come very late because because the child is not complaining of anything. Okay, no question, isn't it? So if there's no question, then let's straight to the next one, which is nephroblastoma.
So I will be continuing the hematology with nephroblastoma.
Not that clear.
Oh, sorry. Okay. Can you hear my voice?
You probably need to shout louder.
Hello? Hello, can you hear my voice?
Can.
Yes.
Okay. Okay, I will be continuing the seminar today with nephroblastoma. So next slide. Okay, this is the outline for seminar. Next. Okay, for introduction, nephroblastoma, also known as Wilms tumor, is the most common primary malignant renal tumor of childhood. Next. Okay, as you see in this diagram, most of the malignant disease in childhood, the most common is hematological malignancy, followed by brain malignancy, and in renal per se, Wilms tumor is the most common. Okay. However, malignant in abdominal tumor of childhood, it is the second most common after neuroblastoma. And the most common site of metastasis are lungs, vaginal lymph node, and liver. And for histologically, Wilms tumor made up from metanephric blastomas, stroma, and epithelial cells. Next. Okay, this is the as we learned in embryology, metanephric blastoma is the precursor for normal kidney. Next slide. Sorry, next. Okay. So in this graph, we can see basically in Wilms tumor, it present in the age of less than 5 years and peak at 2 to 3 years old. So it can arise from one or both kidneys. However, unilateral much more common as compared to bilateral, which consists of 7% of the case. And most cases are sporadic. However, some will have a family history of nephroblastoma. And in syndromic or familial case, there will be early age of diagnosis and high incidence of bilateral kidney disease. Next slide. Okay, for etiology. Basically in Wilms tumor, the exact causes is unknown. Next. Next. Okay. So basically it's arrived from primitive metanephric blastoma, which is a precursor for normal kidney. In sporadic tumor, there will be a Wilms tumor gene or WT1 gene mutation and deletion. And this mutation associated with the syndrome known as WAGR syndrome and Dennis-Drash syndrome. In Wilms tumor also, there can be imprinting of the chromosome 11 and lead to overexpression of insulin growth factor 2, which is one of the tumor regenesis, and it is associated with the back with Wiedemann syndrome. Next. So basically, nephrogenic RAS, which defined as the foci embryonal cell, should be absence in normal infant kidney. However, it is persistent in Wilms tumor bearing kidneys. Next. And if the tumor have a mutation of P53 gene, it can be associated with anaplastic tumor and lead to poor prognosis. Okay. Next slide. Okay, for associated syndrome, as I already mentioned just now, some of the mutation in like WT1 mutation gene, there will be some syndrome that associated with this Wilms tumor. Okay, the first one is the WAGR syndrome, which defined as Wilms tumor, aniridia, genitourinary abnormalities, and mental retardation. Next. So this is the picture for the WAGR syndrome. And basically in WAGR syndrome, there will be anuridia, which means that the partial or complete absence of the iris, and urinary abnormalities, as well as mental retardation. Next. This picture showing the Dennis-Drush syndrome, also related to Wilms tumor, which early onset of renal failure. Next. Next picture. Okay, this showing for Beckwith-Wiedemann syndrome, which showing organomegaly for which liver, kidney, adrenal, and pancreas, as well as microglossia and umbilical hernia. Okay, next slide. So basically, clinical features in Wilms tumor, it is most common presentation is the abdominal mass. This abdominal mass can be found by the parents during bathing or clothing her or his child. So usually it can be large mass at the presentation because as we all know, kidney is the retroperitoneal mass. So it can grow without any strict anatomic boundaries. And also if the kidney that affected is only unilateral, the opposite kidney can still reserve the good function and thus make it less likely to be detected early. Another features can be gross pendus hematuria, as well as hypertension, which with 25% at presentation. This is due to increased renin activity, abdominal pain for about 40% of the case, constitutional symptoms like fever, loss of appetite, loss of weight, rapid abdominal enlargement, and anemia due to bleeding into the renal parenchymal and pelvis. And there will also presentation like pulmonary embolism due to dislodgement of intravascular tumor. Next. So for diagnosis, if a child have abdominal mass, it should be considered malignant until diagnostic imaging, lab finding, or any pathology can define its true nature. So basically, there are a lot of differential diagnosis in regard to malignancy in abdominal and pelvic tumor, like in the diagram at the right side, which is like Wilms tumor, neuroblastoma, non-Hodgkin lymphoma, and others. Other differential diagnosis that we should consider, like hydronephrosis, polycystic disease of kidney, benign renal tumor. Okay. Next. So for us to diagnose Wilms tumor, we have to do investigation like imaging. For example, abdominal X-ray, ultrasound, or CT abdomen to really define the origin of the mass. Is it really renal or adrenal mass? Because adrenal mass could be cause for neuroblastoma, or is it as a origin for other masses? And other than that, abdominal ultrasound can help us to differentiate solid from cystic masses. However, Wilms tumor might show some focal area of necrosis or hemorrhage due to obstruction of the renal pelvis by the tumor. Ultrasound with Doppler imaging also quite helpful for us to know the extent of the tumor. CT TAP also important for staging purposes, and also to look for integrity of the contralateral kidney. And then if the by histological, if we confirm that this Wilms tumor is a type of clear cell sarcoma, and red dot tumor of kidney, we can do a bone scan to look for any bone metastasis and CT brain. And histological examination of tumor can be done by at the time of nephrectomy or by using core needle biopsy. Other investigation include full blood count, coagulation profile to look for any microcytic anemia, might be due to iron deficiency anemia or anemia of chronic disease. We can also look for polycythemia, elevated platelet count, and acquired deficiency of bone volume factor or factor 8 deficiency. For urine analysis, we can also do to look for any macro or microscopic hematuria, and renal profile to look for urea creatinine level as we to know the function of the contralateral kidney. Next. Okay, this is the staging for Wilms tumor. Actually, okay, this staging is according to children's oncology group. They have about 5 stages, and the 5th stage is where the renal involved is bilateral renal involvement. Next. And so for management, basically, there are few treatments can be given to patient with Wilms tumor, including chemotherapy, surgical, as well as radiotherapy. However, different country have different sequence of the treatment. For example, in American, they will done the surgical first and followed by chemotherapy. However, in like Europe, there will be surgical first. They will do chemotherapy first and followed by surgical. And for prognosis, basically, Wilms tumor have a good prognosis with a more than 80% of the child will be cured. However, if there is metastatic during the onset of during presentation, the cure rate might be more than 60%. And if the condition relapse, it might carry poor prognosis. And for complication, if the complication from the renal itself, we are afraid of a renal failure, especially if the kidney is involved, both of the kidney are involved, and most of the complications are due to consequences of the treatment itself, with chemotherapy and radiotherapy, like congestive heart failure, and others. Next. Okay, this is basically a summary. We can from the malignant disease in children, we can see Wilms tumor is a malignant disease that occur in preschool age, which is less than 5 years old. Next. Okay, this is the other pediatric renal tumor, which is a benign renal tumor. You can read it later. Okay, that's all.
Right, thank you very much. So basically, in pediatrics, when talking about renal tumor, we basically solely exclusively talking about Wilms tumor, and the rest of them is very rare. We don't really think about that at all, because at the end of the day, when you suspect tumors from raising from the kidneys, you do a biopsy, and then that will either confirm Wilms or not Wilms. But most of the time, I would say more than 95%. Most of the time are Wilms tumor. Okay, any question to your colleague? Someone fikir nak balik nak habis ni. Okay, so the last one, which is brain tumor.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Afiq Muhammad Shahrin. Today I'm going to present about brain tumors, which is the last part of our presentation. So next. Here is my outline starting from the anatomy up until prognosis. So first, let's take a look at the anatomy of the brain. So nervous system can be divided into central and peripheral nervous system. And in central nervous system, we do have a brain and also spinal cord. Brain is made up of many specialized areas that works together, such as cerebral cortex, brainstem, basal ganglia, and also cerebellum. So it can simply divide it into based on the lobes, and according to lobe, it have a certain function. For example, frontal lobe as cognitive function, parietal lobe for motor sensory, occipital lobe for visual system, and also temporal lobe for memory and hearing. And the brain itself is covered by a layer called meninges, which contain cerebral spinal fluid in between the pia mater and also arachnoid. Next, here I provide how the circulation of CSF, which is produced in the ventricles and act as a protection to the brain and also spinal cord, and then being absorbed via bloodstream. Next. Moving on to the histology part. So nervous system have two different types, which are neurons and also neuroglia. So neurons is basically nerve cells, which is a acceptable cell, which stimulate activation of another neurons, muscle, and also glands. And second part is neuroglia, which is a non-nerve cell, which comprises of astrocytes, oligodendrocyte, microglial, epidermal cell, and also Schwann cell. So these all neuroglia or non-nerve cell have their own function. For example, next, for astrocyte, it form a blood-brain barrier. So this is a picture of astrocyte. And then oligodendrocyte work as a myelination of axon, microglia as a defense system, and also epidermal cell as a lining of ventricle and also spinal cord. Next, in terms of epidemiology, so brain tumor become the most common solid organ tumor, which can be found in the infant and also children 5 years old, 5 years old or younger child. So the etiology can be divided into primary and secondary. Next slide. We have primary and also secondary. So basically, secondary come from the metastasize from the other parts of the body or any organs. And for primary cause, there are several risk factors which are highly associated with progression of brain tumor. For example, exposure to ionizing radiation and also genetic predisposition. For example, in brain tumor is associated with neurofibromatosis, von Hippel-Lindau syndrome, and also tuberous sclerosis. So in physical examination, we need to find these all physical sign of the genetic problems, which can be a risk factor to the progression of brain tumor. Next, we go through the classification of brain tumor. So based on WHO, the classification of the brain tumor is based on the cell type or cell origin, and it is being graded depend on the behavior of the cell. So next, next slide. So these are few classification of WHO, and I only focus on 5 different types of brain tumor. First is astrocytoma. Next. Okay, astrocytoma, based on its name, it originate from astrocyte, which I have mentioned before. It is a non-neuronal cell which act as a blood-brain barrier. So this is the most common malignant brain tumor in childhood. So astrocytoma can be found either in the cerebral cortex and also brainstem. So this brain tumor account for about 40% of the total cases of brain tumor. Next, we go to medulloblastoma. So here the astrocyte Okay, medulloblastoma, which is exclusively occur in the cerebellum. So as we all know, cerebellum mainly tackle about the coordination and also balance. So the children may present with truncal ataxia, coordination difficulties, and also abdominal eye movements. So medulloblastoma account for about 20% of the total cases, and it is a fast-growing tumor in which it can metastasize to meninges and also spinal cord. Next, if the tumor is bigger enough, it may compress the fourth ventricle and causing hydrocephalus. So here the simplest form how to understand the medulloblastoma, about the presentation and also the treatment. Next, we go to ependymoma, which is arise from the ependymal cell, also a non-neuronal cell that lines the passageway of CSF. So it is made up of cuboidal or low columnar in shape and has luminous cilia for propulsion of CSF. So in children, the ependymoma is mostly occur intracranially compared to adult occur in spinal cord. So the children may experience symptoms such as headache and also seizure, compared to adult may present with body weakness. Next. So ependymoma can be further graded into three, grade 1, grade 2, and also grade 3. And the grade is depend on how fast the tumor grows and also the behavior of the tumor cell itself. Based on the reference that I refer, the behavior of this tumor is behave like medulloblastoma, the second type of cell tumor. Okay, next, brainstem glioma. As the name implies, so it mainly occur in the region of brainstem and commonly found in the pons for about 60%. So it can be divided into focal and also diffuse type. So the diffuse type brings a poorer prognosis, as it is a fast-growing tumor and can spread throughout the brainstem. So the children may come with triad of cranial deficit, pyramidal tract symptom, and also ataxia, because the tumor mainly invade the brainstem. So there are a lot of cranial nerve that located at the brainstem. Lastly, we go to craniopharyngioma, which is a benign cystic tumor, which is arise from the pituitary stalk, and also that arise from the pituitary stalk. Thus, the children may come with some endocrine abnormalities because it tackle the pituitary stalk. And then because of the location of pituitary stalk is adjacent to optic chiasm, so the children also may manifest some visual problems such as bitemporal hemianopia. However, this kind of brain tumor is a slow-growing tumor, so the children may come late, or the result it will result in a late diagnosis. Okay. Next, we go to clinical manifestation. So basically, brain have a different compartment or different lobes. So it brings a different function of the lobes itself. So the clinical manifestation is different according to the site of the tumor itself. But the most important part is when we talk about the brain tumor is related to increase of intracranial pressure, increase ICP, because the tumor itself is occupying the space in the brain, space occupying. Okay, so generally they will present with persistent or recurrent vomiting, seizure or body weakness, and more specifically, if the tumor arise from the, for example, from the cerebella, so the children may face problem with balance, coordination, and also walking. As I mentioned, if the tumor arise from the pituitary, so they may come with the symptom as I mentioned before. Next, in terms of investigation, so brain tumor is best characterized on MRI. So here I provide a picture of a magnetic imaging resonance MRI of a brain tumor. Okay. Second, we can do lumbar puncture for CSF examination because some tumor, for example, medulloblastoma, can metastasize across the meninges, and we need to do lumbar puncture to look for CSF examination. However, we need to uh, we need to uh, uh, we need to uh, to think about the consequence lah. If we do lumbar puncture, if we suspect the patient have ICP, so it is highly contraindicated. Next, magnetic resonance spectroscopy, which can examine the biological activity of the tumor. So it help us in terms of monitoring of the condition of the patient during follow up. Okay, in terms of management, next, we can give a high dose dexamethasone to reduce tumor associated edema, but the primary treatment is surgery in order to treat hydrocephalus, provide tissue diagnosis, and also attempt maximum resection of the tumor itself. In terms of radiation therapy and also chemotherapy, is often combined both of these therapy, and some tumor is sensitive to chemotherapy, for example medulloblastoma, and give a good prognosis, and some tumor, for example brainstem glioma, is less sensitive to chemotherapy. Okay, and the last part is overall prognosis of survival rate associated with childhood CNS tumor, which is account for about 50 to 60% of survival rate. However, in certain types of tumor, for example, brainstem glioma, because of the activity of the tumor itself, so the survival rate may be less than 10% of survival rate. Okay, I think that's all for brain tumor.
All right, thank you very much. So have you got any question about brain tumors? So the main thing about brain tumors, you take it very seriously lah. If you got a child ataupun any children's less than 5 years old complain of headaches, take it very seriously because most of them don't really know what headache means. So if you got somebody, or if you got a child that complain of headaches, or if you ask them where they got pain, so most of the time they will point out to their tummy when they got pain. Even though they got headaches, they point out to their tummy. But if a child, if you got a 3 or 4 or 5 years old, saying that they got headaches and they're pointing the source of the pain is to the head, take it very, very seriously because that could be the only signs that they might have at the time. Because sometimes tumors can be slow growing, so it might take a few months to grow, but the symptoms can be very subtle. It could be just a bit of just nausea in the morning, bit of intermittent headaches, and sometimes the child can have change of behavior, just a behavioral change. Can be the only signs that could be the only symptom that could point to brain tumor. I have one of my colleagues, Charles, who basically 2.5 or 3 years old at that time. This is 5-6 years ago. When he basically finished his work, he went home at night, and then went to see his child, and then he was so shocked because his child does not recognize him. His child says, "I don't know who you are." So because of that, he was very, very surprised and very shocked. So he brought her to ED department and get a CT scan, which later shows she does have a posterior fossa tumor. So just a very minor thing that could be the only symptom that they have to suggest a brain tumor. And I think in our medical center, we also have a few children that come in with vomiting in the morning, nauseas, not really themselves for like 2 to 3 months. And then when we do the scan, it's a posterior fossa tumor, and some of them basically we can't do anything at the time because it's already advanced, and the child probably has a corning symptom and corning sign already by that time. So the learning point for brain tumor is for this session, for this topic is do not take a headache in children do not take it for granted. So take it very seriously. Any question you guys have? It's been more than 3 hours already. So any question you can ask now. If there's no question, we can adjourn our session. Okay, any question? Aziz Market, tak share. Okay, there's no question, and that's fine. This is my last teaching with you guys, because I'm not doing any more online teaching after this. All the best. The only thing I would say is all these topics that you're presenting, the dermatology, the oncologies, because we normally use your slides for KFQs, could be mainly for your MCQs. So do read them. Because we probably take some points from your slides, but anyway, all the best. Good luck. I might see you whenever you're doing your final pro in next couple of years. Thank you for attending this session. Then we're going to adjourn our session with Tasbih for Rasulullah. Okay, thank you very much. Thank you. Right. Assalamualaikum.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.